Good evening and welcome to our Learn and Share conference call. I'm Russ Derry, Director of Education for Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for tonight is integrative medicine in the management of epilepsy, and we're pleased to have as our speaker Dr. Tyson Burghardt, who is an epileptologist with Michigan State University. So Dr. Burghardt, can you briefly introduce yourself, talk a little bit about your clinical and research interests, and describe your experience with this topic?
I'm Tyson Burghardt. I'm an associate professor at Michigan State University. I practice at Michigan State University and at Sparrow Hospital and McLaren Hospital. I'm primarily work with folks who have epilepsy or other paroxysmal disorders, especially functional neurological disorder. And I'm the medical director of the Neurophysiology division at Sparrow Hospital. So my interests deal a lot with electroencephalography and continuous monitoring. But on the patient side, or on the clinical side, I should say, my approach tends to be very focused on the patient-physician relationship, and so I do come across folks who bring up complementary and alternative therapies quite a lot, and I try and work with my patients at all times so that we can settle on an agreed upon negotiated treatment plan that is acceptable to both of us, that seems to meet at least some of the scientific rigor that my profession tends to demand, but that also affirms the fact that we don't know everything and that patients can bring a lot to the table.
Great. And that's exactly the kind of balanced approach that I'm hoping to have with our conversation tonight, because it is a tricky topic and there's a lot of gray area, and I think exactly how you described it is my philosophy as well. So for the purposes of this call, we'll be using the terms integrative medicine and complementary therapies somewhat interchangeably, but I think it's worth specifically discussing what integrative medicine means. So many of the definitions that I've seen for integrative medicine sound essentially like an ideal vision for what medicine as a whole should be. For example, the American Board of Physician Specialties defines it as the practice of medicine that reaffirms the importance of the relationship between the practitioner and patient, focuses on the whole person, is informed by evidence, and makes use of all appropriate therapeutic approaches, healthcare professionals, and disciplines to achieve optimal health and healing. So it sounds pretty good. So do you agree that our healthcare system as a whole should kind of aspire to that vision? And if so, what elements of that vision is the current system maybe struggling to fulfill consistently?
I agree that that's essentially very aspirational. It's
right.
And it's worth, I suppose, starting with the fact that medicine has not always even embraced this kind of thing. Before the Flexner Report in 1914, and even afterwards until the advent of penicillin and other things, like there were some zany ideas that took permanent root in the minds of people who would otherwise be considered learned experts. That said, what we hope is that, especially since World War II or thereabouts, that there have been that medicine as a whole has been increasingly demanding of a proper basis of evidence for the effectiveness of the treatments that we do. And that doesn't always exist. In fact, it doesn't exist in a lot of cases. Part of that is because we have some treatments that are sort of grandfathered in, that we just kind of know work, but whose started to be used before the modern era of evidence-based medicine, and in the seizure world, phenobarbital is basically that. Phenobarbital was accidentally stumbled upon by an Austrian house officer who was just trying to get his epileptic patients to go to sleep, and found that they had fewer seizures as a result. And in other cases, the lack of evidentiary basis for some of what we do also comes down to the fact that it's very hard to do good scientific studies in human beings. There are a lot of variables to control for, a lot of things that, because they can be very different between different people, can really throw off your analysis and make it seem like things work when they don't, or don't work when they do. And doing good studies requires a lot of time and a lot of money, and oftentimes, unless it's a large pharmaceutical company or a device company trying to basically satisfy the FDA's need for evidence for their new drug, that time and money can be in short supply. So
Right.
that is our aspiration. We want to get to that kind of point. And I'm thinking, like, just as a sort of circumferential point here, in astronomy, the findings are dominated these days by the large scientific consortia that own huge telescopes on top of mountains. But there are still very important, if not headline-catching, discoveries that are made by very dedicated amateur astronomers in their backyards, going out and doing the work every night with their smaller telescopes and their less expensive equipment. There's no monopoly on truth, certainly, and there's no saying that only these people can possibly know what works and what doesn't work, and things like that. And so I think a number of folks in my profession are a little too quick to dismiss certain therapies and things that are brought to the table. Part of that is that, well, sometimes we've heard of the same old song and dance in different guises, and we know that certain things are proven not to work, and just because they gave it another name doesn't mean it's going to start working again. But other times it's just because every once in a while it might just be because, I never considered that before, and I don't think anyone else has either. But why would you know that? Why would you, a non-scientist or non-physician, know that? And that's that kind of attitude. And it's not always present, of course, in such a dismissive way, but that kind of attitude is the sort of thing that can taint the physician-patient relationship, where it's like, well, there's no way that you could possibly know more than I do, the learned physician, so I'll just dismiss this out of hand.
Right. That's a great point. Yeah, so we talked about, you mentioned the evidence that is typically used for evaluating conventional medical treatments, and for epilepsy, currently that kind of includes, the main ones are anti-seizure medications, neurostimulation devices, brain surgery, and ketogenic diets or metabolic therapies. So can you talk about that level and type of evidence that supports the safety and effectiveness of these treatments, and then how that compares to the types of evidence that we may have for what are currently considered complementary therapies?
So, apart from certain things that are older than dirt, like phenobarbital,
right?
The majority of treatments that we use for epilepsy today have gone through processes of randomized controlled trials, RCT for short, and this is generally considered a gold standard for demonstrating that something, quote unquote, works or doesn't work. And it involves finding a bunch of people splitting them into usually half and half, not always, and then giving half of them the new thing that you want to try, a new anti-seizure medication, for instance, and half of them a sugar pill or a pill that doesn't really contain anything that we expect to be useful. That would be a placebo, in the Latin, I will please, placebo. And the main thought behind this process is if you have a large enough sample, then everyone's variation is going to kind of cancel out in the average. And if you are giving half of these people or some number of these people the active treatment that you think is going to work and half of them something that shouldn't really do anything at all, then the response in the case of epilepsy usually measured as the percentage of reduction in seizure frequency, for instance. The response should be different, should be hopefully higher in that case, among the people who took the drug under investigation versus those who took the placebo. You may have heard of the term double blind, and double blind RCTs just means that neither the subject, the patient, nor the people who are treating them know, they're blinded to whether that person is taking the sugar pill, the placebo, or taking the actual drug of interest. And that's done in order to reduce the chance that that bias may be introduced by thinking, oh, well, I'm taking the drug, so it must be working, or, oh, hey, this patient's taking the drug, the seizure reduction they're reporting must be because of that. So that's sort of the gold standard for establishing the efficacy of treatments for epilepsy, and basically any of the medications introduced since valproic acid, so almost all of them, as well as the ketogenic diet for at least some types of epilepsy, and surgery in several different types of epilepsy. They're all backed by randomized controlled trials, usually blinded. It can be very hard to blind for surgery. You either got your head cut open or you didn't. And this also looks aside from the fact that epilepsy is, as people in the call certainly know, is not a homogeneous disease. There are different types of epilepsy, different types of seizures, different types of syndromes, different types of causes. And modern RCTs for anti-seizure meds have tended to focus on people who have adults who have drug-resistant focal epilepsy, who have focal seizures, like focal aware or focal unaware seizures, with or without generalized tonic-clonic seizures as well. And that matters because if we blindly make the assumption that these things work just as well in other populations of epilepsy, that may, I'm not saying it does, but it may lead us astray. It may, those may not be, as we say, generalizable results. Nevertheless, and then part of that comes down, of course, to the questions of cost and time. And when we look at integrative therapies, complementary and alternative therapies, some of these have more evidence behind them than others, and some of them have evidence more for other indications than for others as well. There is some body evidence for acupuncture in the treatment of a couple of different conditions, for instance. Nothing that I know of that indicates it's really all that effective for epilepsy, but it may be effective for things like chronic pain and things like that. Other things may not have much evidence behind them at all, or may only have the evidence that the manufacturer claims to have from their own private clinical trials. And I'm thinking of a number of different nutritional supplements, for instance. Some of that is driven by the fact that if a manufacturer creates a proprietary blend of herbs or other things, they may not be super willing to to allow that to be tested in a rigorous manner because they don't want to give up their trade secrets or this or that. Part of it can certainly be because time and money. Clinical trials in human beings cost a lot of money, millions, if not tens and hundreds of millions of dollars in some cases. And companies that produce things like nutritional supplements are not likely to be able to raise the capital for that.
Right.
And then it sucks to say, but there are certainly a lot of things out there that are claimed to be effective for different medical conditions, including for epilepsy, that just have no possible basis in fact, and whose manufacturers I usually suspect, although I certainly can't prove in most cases, that I suspect are just trying to hoodwink people.
Right. Right. And I imagine, another aspect or of evaluating a therapy is also just the number of people in a study, because I can think of a few different kind of complementary therapies that have had studies done, but it's small studies of 20 people, and it's, so probably the sample size and the number of studies done also plays a role in kind of evaluating that level of evidence.
That's a very good point. It's, when I first started learning about what clinical trials do and so forth, it would not have seemed obvious to me that having 20 or 30 people in a study would be all that problematic. But the fact is that random results happen all the time. You don't always get 50% heads when you're flipping a coin. You don't always get an even number of ones and sixes when you're rolling dice. We expect we expect that in the excuse me. We expect that in the long run that those will hold true, but just getting over a head cold. I apologize.
Oh, no worries.
We expect that in the long run those probabilities hold true, but anytime you do it for a short period of time, or in other words, anytime you run a clinical trial for a short period of time on a relatively small number of people, it's not unheard of and not in fact unlikely to get results that you think are supportive, even though they might not actually be.
Right. Okay, so generally speaking, when deciding whether or not to try a complementary therapy for epilepsy, what are the main criteria you use as an epileptologist, and what criteria should patients use?
The things I typically think about are, does it seem plausible that this sort of thing could work? For me, a lot of homeopathic therapies, at least the way that they are advertised to work, does not make much sense in light of everything that science knows about chemistry and biology, for instance. And it doesn't mean they can't work in other ways, but the way they're claimed to work, yeah. Another thing I tend to think about is what are the possible adverse effects? Because there's no treatment whatsoever. There's no substance you can put in your body, including water, that can't cause adverse effects at some dose or at some, or given at some specific time. And when we're thinking about therapies that could potentially cause harm just as they could cause a benefit, it's important to think about. When you have therapies that don't necessarily have a lot of evidence behind them, just because they are claimed to be all natural doesn't mean that they are, without potential side effects. Plenty of stuff that's natural can kill you. Plenty of stuff that's artificial can do you well. I also think about whether there's a likelihood that the proposed therapy could interact with the therapies the patient is currently on, particularly if you're taking some anesthesia medications that are known to be metabolized by your liver, for instance. Then we're always kind of looking out for drug-drug interactions that can happen because of substances that either speed up or slow down your liver's metabolism of various substances. And again, there are a number of integrative therapies that at least potentially could have some of those drug-drug interactions. And we would hate for instance, for someone's seizure control to worsen because the amount of anesthesia medication they're taking is no longer enough because the drug-drug interaction with the integrative therapy is caused the level to fall in their blood. And I also think about cost, because many alternative, complementary, and integrative therapies are not going to be covered by insurance. And they can end up costing quite a lot out of pocket, maybe not particularly for a single bottle, for instance, but taken on an everyday basis can cost quite a bit. So I'm really looking for things that have a plausible basis to potentially work, that have a reasonably low likelihood of causing anyone harm or interfering with the therapies that already exist, and that are reasonably attainable by people, whether that's cost-wise or otherwise.
Yeah, makes sense. So let's look at some of these criteria individually. So starting with safety, we know that there are thousands of products marketed as having health benefits that have really no requirement to back up those claims or to demonstrate that they're safe. With that in mind, it's important to let your medical team know about any complementary therapies that you're using, preferably before you start using it. But as you mentioned, in some cases, products can interact with anti-seizure medications or even directly increase the risk of seizures. Are there any specific complementary therapies, that have been either promoted for epilepsy or for other conditions or just for general health benefits that people with epilepsy should avoid or at least use with caution because of these risks?
One big example is like St. John's wort, which was marketed quite heavily a while ago. I think to a certain extent still as a treatment for depression, among other things, and for which there's a little bit of evidence. But St. John's wort is one of these things that can affect the liver's metabolism of other drugs, including some anesthesia medications. Even grapefruit juice can affect the metabolism of some anesthesia medications. So it's important with users of St. John's wort or really any other sort of herbal supplement to let your medical team know about it beforehand. The other thing is that sometimes, what's put in some of these herbal supplements and so forth, we might not actually have good evidence about how they might affect the liver's ability to metabolize stuff. So even if you tell me or your physician what you're taking, it might not necessarily be enough information to say that it's definitely not going to interact or definitely will interact. We at least don't have the situation where, unfortunately, like with a number of cancer therapies, we have some which have been actively harmful to folks, like Latreel, as a for instance. And I don't, off the top of my head, I can't think of anything in particular that's super harmful to folks that's been marketed towards epilepsy.
Okay. That's good to know.
Yeah.
Yeah. So, and I mean, again, talking about herbal supplements and things, and many kind of products that you could find on the internet or in a health food store. A lot of times, you may not know exactly what's in there, anyways. That's another danger is that there's not necessarily a requirement to say exactly how much of each product and each ingredient is in there, or is there? As far as I know,
Well,
there can.
as a matter
I mean,
of fact,
at least with. Yeah, go ahead.
yeah, it's worse. The U.S. Congress passed a law in the 1990s, the Dietary Health and Something Act, DHEA, I forget the total name, which completely exempted manufacturers of natural and herbal supplements from having to be accurate in any way about the things that are contained in their products. And honestly, sometimes that scares me a lot more than what actually is supposed to be in the product. The idea that there's there's no regulator looking out for quality control. There's no one looking out to see that what they claim is in the bottle is actually in the bottle, or for that matter, that nothing is in the bottle which shouldn't be in the bottle. And so that's the sort of thing that if the wrong kind of chemicals are in that bottle, it could interact with your anti-seizure meds, or it could be a proconvulsant in and of itself. And how would I know unless I ran it through a sophisticated mass spectrometer gas chromatograph, which I don't have. I would.
Right. Okay, so now let's talk about some complementary therapies for which there may at least be some published evidence of effectiveness in reducing seizures. Have you come across any either dietary supplements or mind-body approaches or other therapies for which we have some degree of evidence of effectiveness, but maybe just not enough to yet warrant more widespread use?
I am not particularly aware of anything that has a good evidentiary basis for reducing seizures per se.
Okay.
What I tend to, which is not to say that I don't have some patients who feel like whatever they're taking might be helpful for their seizures. Folks who are taking curcumin or turmeric-based things, or large doses of different kinds of vitamins. I'm not aware of any robust evidence that these sorts of things can reduce seizure frequency in folks. But when people are taking them and it doesn't seem to be harming, and and it seems like they've tried without and they've tried with and then have fewer seizures, then that in itself is a form of evidence. It's not a randomized controlled trial, but it is a form of evidence. On the other hand, as the callers will also know, epilepsy is not just about seizures. Even people with completely controlled epilepsy and no seizures may still suffer from depression, anxiety, cognitive problems, and a host of other what we would label neuropsychiatric problems with epilepsy, problems with their mood and problems with their motivation and things like that. And for that, at least not necessarily with epilepsy per se, but in general, folks with mood disorders and anxiety disorders and cognitive disorders, there is a small modicum of evidence for certain things, music and art, therapy, recreational therapies, yoga, meditation, relaxation techniques. Mindfulness training seems to be very in vogue among psychiatrists and psychologists for anxiety disorders these days. And it's it's an easy, low side effect kind of technique that can in many folks, not all, but in many folks, really alleviate psychological distress. And we remember that psychological distress, one form or another, is a very common comorbidity with epilepsy. It doesn't just happen because one has seizures, but sort of happens because of the way that seizures remodel the brain. Then these things can be very helpful, especially if you don't want to choke down yet another pill.
Right. So one thing that has been brought up a fair number of times in talking with clients is neurofeedback, and that's one of those treatments that seems, at least on the surface, to make sense as a potential treatment for epilepsy. Talking about that kind of biological plausibility that you mentioned earlier. So basically, it uses operant conditioning to promote electrical activity in the brain that's less likely to result in a seizure. So in most cases, people will be kind of hooked up to a rudimentary EEG setup and will be doing something like a video game, and basically if your brain waves are in a desirable state, then your video game will proceed, and if they go into a state that is pro-convulsant, then your video game will stop proceeding. It's kind of a overly simplistic description of it, but basically how it works. So is the fundamental principle of neurofeedback sound, and if so, again, what's preventing it from being more widespread or used in a widespread fashion, I guess?
The principle is not unsound, which sounds a little weaselly. And it's true that a lot of things that we normally think of as being completely beyond our voluntary control may actually be controllable, at least to some extent, with certain techniques like biofeedback or neurofeedback, which is just one type of biofeedback.
Right.
Not aware of any studies that have shown that it is particularly useful in reducing seizures. And I think at least the medical community, doesn't yet fully understand the electrical dynamics in the brain that give rise to seizures well enough to know whether those dynamics could even be plausibly affected by voluntary control. But in the sense that it's a therapy that at least claims to alter brain connectivity, then it is conceivable, although not necessarily true, but it is conceivable that could be effective in some way. I think what hampers some of that is, what would potentially hamper research into this sort of thing would be the lack of standardized neurofeedback technique. In order to study something, you generally need to be able to reproduce it so that you can do it over and over and over and over and observe the results. And my impression, having actually talked with some biofeedback practitioners who became our EEG technologists at Spare Hospital, was that different places, different companies, different practitioners will have different approaches in how to do this. So you would have to figure out, which kinds of neurofeedback to actually try, and then try that in a randomized control trial. And if that doesn't work, then think about others. So it becomes a little complex unless someone comes up with a reason why certain set of neurofeedback techniques might be more effective than any other. And then, in principle, you could test just that.
Okay. Yeah, and I seem to remember reading at some point that whatever effect that you might get from neurofeedback doesn't necessarily last once you stop doing it, and that it can be fairly time consuming and costly. So, those would be certainly other considerations that might be holding it back from even being researched further. So, okay, so no discussion of complementary therapies is complete without mentioning cannabis, of course. So while cannabidiol has crossed over from complementary to a conventional treatment in the form of Epidiolex, many other forms and uses of cannabis have not been FDA approved and are still widely used by people with epilepsy. So are there any such uses or forms of cannabis that are either particularly concerning to you as an epileptologist or that are particularly promising and would warrant further study?
I think, I think it's still not clear whether. Well, let me start off by saying, cannabis has 70 or more different phytocannabinoid chemicals in it. And
Right.
the two most common ones, or the highest concentration ones, at least in most cannabis plants used recreationally by humans, are THC and cannabidiol, or CBD. As you mentioned, CBD is useful as an anesthesia medication, although at fairly high doses compared to what you can get at a dispensary, for instance. Patients have showed me the different bottles of Rick Simpson's oil or Charlotte's Web or other types of CBD oil preparations. And when I look at the label and do the calculation, the amount of CBD that's claimed to be in that is approximately equal to 1 day-ish of therapy with Epidiolex in terms of the dose that we feel is necessary for seizure control. It's not to say that lower doses couldn't be effective. This was, after all, tested in a population of people who had very severe types of epilepsy, Dravet syndrome and Lennox-Gastaut syndrome. But using very small amounts of CBD, I don't know how super effective it really is. But THC, there have been, to my knowledge, no trials in human beings of THC as an anesthesia medication. Animal models, so an animal model is when you develop a process for seeing what seizures look like in a given animal in a given scenario, and then finding out how well you can treat that kind of disease with different medications or devices or whatever, and hoping that there's enough similarity between the animal and a human being that it crosses over. So in a number of different animal models, THC has different properties. In some of these models, it seems to suppress seizures to a certain extent. In some of these models, it actually tends to promote seizures to a certain extent. It's not, I don't think anyone can say how well I don't think anyone can say that it is particularly a good anti-seizure, nor that it's a particularly bad pro-seizure kind of drug. If it were obviously one or the other, I think, especially given how much cannabis some of our patients do use, that we'd figure it out by now. So if there is an effect, it's probably on the smaller side, but we don't really know. the effect, my thought is the effect must be small enough that, especially compared to, the being on a good stable therapy and so forth, that I don't particularly, I'm not very militantly against people using cannabis if it brings them some peace or some relief or some satisfaction in some way. And again, this can be beyond seizure control in and of itself, because smoking or eating cannabis products does help with quite a lot of folks who have anxiety, or even sometimes treatment-resistant depression. And I certainly don't ever want to overlook those kinds of symptoms, which can be, in some cases, just as disabling as the seizures themselves.
Right.
I've had a few patients who had some troublesome seizures, and then when they finally stopped smoking cannabis entirely, the seizures kind of went away. But I've also had plenty of patients tell me that cannabis definitely improves their seizures, reduces the amount of seizures that they have. And without being able to, take a whole bunch of them and randomize them. And again, I don't know how you would randomize smoking pot or not smoking pot, but it's difficult for me to say that for any given person, it's definitely going to work or not going to work. But again, that's not the only bit of evidence that we have to bear on any question. What a single person tends to find effective or non-effective, if not necessarily generalizable to the entire population, at least says something about what helps him or her. So
Right.
I don't have a strong feeling that THC is very helpful. Cannabidiol or CBD is demonstrably helpful, but the effects that we know about tend to happen with very, very high doses. There are, as I said, many other substances in the cannabis plant, and several of them have been the subject of study, including cannabidivarin or cannabidivarin. Who knows how to pronounce these things? And you may, of course, and it's very possible that down the line some of these things might become medications for one thing or another as well, depending on how the studies pan out. But aside from that, I provided that the patient is definitely over the age of 21 and preferably over the age of 25, I don't particularly have a problem with them using cannabis. The reason to be very cautious in younger people with using cannabis is that there is there is a statistical and probably causal correlation between cannabis use in the teen years and with the onset of schizophrenia. Certainly not everyone who has schizophrenia got it from using weed. Most have not, as a matter of fact. But there's pretty robust evidence that at least some small number of cases of schizophrenia have at least been partially caused through the use of cannabis. And that danger largely subsides by the mid-20s. Schizophrenia cases are becoming much more rare after that. But that's a really good reason for me to recommend against it in young folks, no matter what.
Can it interfere with brain development as well? I seem to remember hearing that at some point in addition to the schizophrenia risk.
Yeah, it quite possibly can. And in fact, the risk with schizophrenia probably comes from its interruption with development. The reason the age of 25, for instance, is important here is because that's around the age where the frontal lobes of most human beings are finally fully developed and myelinated. So after that, it's all kind of downhill for every one of us. I mean, no surprise there, right?
Right.
Not really, of course, but After that, brain development is sufficiently complete that it doesn't seem to be nearly as affected.
Right.
And the cannabinoid chemicals contained within cannabis, they work with a system of receptors, of biological receptors on your cell surface, on brain cell surfaces, that already exists. The endocannabinoid system, and this is the case with a lot of drugs, actually. Like, your body's evolved one way of signaling itself to do things, and then we find plants or other things that contain chemicals that also coincidentally, interact with those same systems in our bodies. The endocannabinoid system has some potent effects on inhibition and other things within the nervous system, reducing excitability, reducing electrical impulses, and so forth. And that sounds very good for epilepsy on the face of it, and yes, we tend to like drugs to either reduce excitability, electrical excitability, or increase inhibition of electrical excitability. But brain development and brain function in general are very dependent on the proper interplay of both excitation and inhibition. So blocking either one in the wrong way, not that we always know the right way, but blocking either one in the wrong way might absolutely interfere with development and maturation of the brain.
Right. Okay, so the placebo effect, we mentioned that before in talking about randomized controlled trials, that the placebo effect is real, and it can actually be quite significant. It's likely that with some complementary therapies, the primary benefits that some people derive are simply placebo effect. And in other cases, a therapy that's administered by a caring practitioner or one that's done so in a soothing and calming manner can reduce stress, and that may be the true benefit of the therapy. The stress reduction reduces that seizure trigger. So should it matter whether a therapy works because of its proposed mechanism of action or because of the placebo effect or some indirect benefit?
In a way, no. In a way, yes.
Yeah, I know.
It should. It should matter because physicians are ultimately, and I guess this is on us, not on patients to really care at all, but physicians are trying to find therapies that are generally useful, that I can use with any person that comes in my office with similar symptoms, similar cause, and it's going to work. And if it's dependent on each time on how I pitch it or how it's delivered, or the particular psychological receptiveness of that person that day, it becomes very difficult to predict what's going to work and what's not going to work. Moreover, things that might work just because of a placebo effect might still harm people for real, that is not from a placebo effect. Parenthetically, there's also something called the nocebo effect, which is the opposite of the placebo effect, when patient expectations that something will hurt them turns out to cause the hurt rather than actual side effects.
Right.
But I think another thing to consider is time. For me, I think in the epilepsy world, a lot of the placebo effect that happens because we tend to escalate treatment when patients are doing less well, and then we don't tend to rewind it when they're doing better. And we now have very good evidence that people who have epilepsy, their seizure frequencies aren't constant all the time. Their seizure severity isn't constant all the time. And the rhythm can be very different from person to person, but you might find that certain times of the year, certain seasons, certain times of the week even, certain times of the month, especially if you're a woman who menstruates, certain times can be associated with worse seizure control, more severe seizures, and then other times with better. And if you are, hypothetically, if you're experiencing worsening seizures, when you go to your doc, or your naturopath, or your anyone, and say, okay, things are worse, what are we going to do about it? It could very well be that the natural rhythm of things is going to bring that seizure control back into the better range on its own over some short period of time anyway. But, if I increase your Lamictal by another 50 milligrams per dose twice a day, and then 3 weeks later you're like, hey, my seizures are better. Was it because of the Lamictal, or was it because they were going to get better anyway? You don't always know. But when your seizures are doing better, physicians who treat folks with epilepsy are less likely to go, okay, well, things are better. Let's reduce that Lamictal dose by 50 milligrams. Because, we all have this desire to not impose new risks, even though we might be imposing some risks with higher medication doses anyway. Like, we know that this worked, so why would we change it? It might make your seizures worse. It might also make your mood better, depending on the drug. But we can all, and I'm not saying patients, I'm saying physicians, we can be very short-sighted about that. And the placebo effect in that case is more about us ratcheting up treatment when things are bad and not bringing them back when things are good. And this can absolutely be the same case with complementary and integrative and alternative therapies, that if your physician doesn't seem responsive and you're like, okay, fine, I'll try this thing, and then things get better. It might not necessarily because you believed it to be better, although in some cases that's true. Maybe because they were going to get better anyway. But now you have a firmer belief in its effectiveness, and are less likely to give it up, even if there turn out to be some side effects. And so you see the placebo effect is one of the reasons we do randomized controlled trials, because we know that for many conditions and many scenarios, you do something, and some people are going to get better no matter what. And in this case with epilepsy, the way that we do randomized controlled trials, I think, lends itself quite a lot to having high placebo effect rates. And we see that any of the medicines that have been released in the last 20 years, the drug trials used to support FDA clearance, FDA approval, often have a placebo response rate of like 17, 20, 25%. Like 1 out of every 5 people who got nothing but a sugar pill still had a decline in their seizure frequency. And, sugar's not all that anti-seizure. It just isn't.
Right.
So that's part of human beings' just continual ability to fool themselves into seeing patterns, either where patterns don't exist or where larger patterns go unnoticed. And that includes physicians as well. And things like randomized controlled trials are around and have been around for decades, precisely because they seem to be one way of preventing us from fooling ourselves.
Interesting. Yeah. And it gets even more complicated when you consider that there's been now studies that have been done that show that even when you tell someone that they're getting a placebo, they can still get the placebo effect, which that I just don't understand that at all. But yep. So medical ethics can even come into play a bit on this matter. And an example that comes to mind for me, and this is not to single out this particular therapy, but Reiki is, for me, seems like a prime example of this, where with Reiki, a trained practitioner acts as a conduit through which a universal life force energy flows to provide a therapeutic effect. So we have no evidence that such energy exists and no way to prove that an individual can manipulate that energy. Nonetheless, we have many major health systems that offer this therapy, often as part of an integrative medicine department or clinic. And presumably they have strict criteria regarding who they hire to provide it, like it has to be a trained individual. To add to this, the language that some health systems use to describe the treatment very much implies that this is a real mechanism by which this is working. So, in your opinion, is that unethical to promote a therapy by citing an unprovable mechanism of action?
I think physicians have an obligation to tell patients what they know and what they think, which also means an obligation to not endorse things that don't make any sense according to their understanding. It is absolutely true that we do not understand everything in the universe. Also true that what we thought we understood in the past has sometimes been overturned. It's also true that much of the things that we know about the way the human body works and the way disease works has been built up painstakingly over decades of incremental research, each bit of which, if you were able to trace it, would make absolute sense. I've never actually had a patient approach me about Reiki in particular, but a large number of herbal supplements in particular, for instance, claim that they can improve epilepsy by ridding you of toxins. And the way that some people for these companies in their marketing departments, etc., the way they talk about toxins, you think it was just this black sludge that exists in everyone you need to get out of you. But as Paracelsus once said, nothing is a poison in and of itself. It's the dose that makes the poison. So when I have patients who are like, hey, I take this supplement, it's supposed to rid my body of some toxins and improve seizure control, I say, well, I don't know about any of this toxin stuff, but it doesn't look like it's harmful. I don't think it's going to interfere with anything. If you feel like it's helping you, cool. Keep going at it. Let's see how well it does and how well it does over the long term. And similarly, for something like Reiki, I would be obliged to say something to the effect of, I don't really think that that's how it works, if it does. But if it works for you, and it doesn't seem to pose a risk of harm, it's possible that it's working through some other mechanism. It might be doing something that we just are not aware of, which is definitely possible. Sometimes what we do isn't beneficial because of the reasons that we think, but for something else. Human inventiveness is wildly crazy in the way that we can come up with things sometimes. But I agree. There's at least I feel that there's an obligation to, like people are coming to you as a physician or another kind of provider. They're coming to you because of your expertise, presumably. And so if you don't share your expertise, including the parts that may be critical of some of the things they would like to try, you're not doing your job and you're not doing right by people. And you might be wrong eventually, but like you can't shotgun in the dark thinking you'll be right some of the time, because you can do a lot of harm trying not to ever be wrong when you should be trying to be right as much as possible.
Right. Right. Yeah, and I agree that, like, with in the example of Reiki and the particular health system website that I was looking at, it would have been pretty simple to just add we're not exactly sure how this works, but some people find it helpful. Would have been, a pretty simple thing to add, and would have, gotten rid of that impression that, hey, this implication that this proposed mechanism that has no proof is the real reason why it works. I mean, even for some conventional therapies for epilepsy, we're not exactly sure why they work. VNS, I don't think we entirely understand the full mechanism of that. I don't think we entirely understand the exact mechanism between the ketogenic diet, and I think in most cases we say that we're not claiming to know every aspect of how even those work. So, anyways,
Correct.
Yep. So, so unfortunately, and you kind of referenced this before, there's many companies and practitioners on the internet that take advantage of the desperation experienced by some people with chronic illness for whom traditional treatments have not yet worked. So what are some key red flags that should lead someone to maybe doubt a therapy's claims? Like, how do you spot quackery or pseudoscience or scams?
Well, that's a whole talk, but I think,
right.
Claims that it works for everyone.
Mm-hmm.
We know that people with seizures comprise lots of different types of people who have lots of different types of seizures, lots of different types of causes. There's no reason to suspect that one thing would help everyone. Claims that it works completely well, that it'll always help, no matter what, and that it'll cure a condition for which, every other professional you've ever met would say, well, we can treat it, we can manage it, but there's no cure. Claims that there are no side effects. Because as I said before, literally everything has side effects. Water has side effects. Vitamins have side effects. As Paracelsus said, it's the dose that makes the poison. There is nothing that could possibly be without side effects unless it has no effect either. And conspiratorial claims, I think, are also a red flag. Claims that this actually is really good, but doctors are suppressing it because they don't want to lose all that lucrative epilepsy treatment business. Not that lucrative. It's fulfilling, personally. Definitely very fulfilling. Or similar claims that the government is suppressing this knowledge, or pharmaceutical companies are suppressing this knowledge. It tends to be red flag.
Right.
And so those are the sorts of things that I would look out for.
Yeah, definitely. So one more question, just kind of going back to the term integrative medicine. I would think an ideal epilepsy center would be kind of a one-stop shop for all therapies that can help not only with seizures but with cognitive and emotional and physical well-being as well. So if you had unlimited resources, what would be on your wish list in terms of both practitioners and services that you would want to have at your epilepsy center?
I would absolutely love to have psychiatrists, psychologists, physical therapists, occupational therapists, as well as neuropsychologists, kind of folks who do testing of mental functions, higher cognitive function, speech language pathologists and therapists, and social workers. Particularly because, I mean, so you said the American healthcare system is way too labyrinthine for most folks to navigate over. And also because folks with epilepsy, compared to other folks without epilepsy, are much more likely to have less money, less wealth, fewer resources to draw upon, more likely to need various kinds of aid or income supplementation, and there are political and other kinds of obstacles to those things thrown up at every turn for folks who need those resources, and that encompasses quite a lot. But that's a lot of the professionals on that list wouldn't be super different. If I were a movement disorder specialist or a headache specialist or any other kind of neurologist, I think, I feel like for many folks who have epilepsy, the desperation can come not necessarily because of seizure control, because we can control seizures in 2 out of every 3 people with epilepsy. I think a lot of folks don't do a very good job. A lot of physicians don't do a very good job helping with the other manifestations: mood disorder, anxiety disorder, cognitive disorder, memory problems, that sort of thing. And there are effective treatments available, but neurologists and epileptologists are neurologists. They're often not not trained in how to do that very well. It's just part of, quote unquote, part of psychiatry. So I feel like you end up having quite a lot of patients who are undertreated insofar as their mental health and their cognitive health is concerned, and who will understandably, no one could blame you at all in that situation, understandably would look to see what else is out there. With cognitive disorders, it's a little tougher. We don't know what works very well for a lot of folks. I do have a number of patients who have sort of executive inattentive kinds of problems. I'll use some methylphenidate or Ritalin or something like that tends to help. But there are tons of kinds of therapy that may be helpful. Things that have been learned from rehabilitation of folks who have traumatic brain injury, for instance, might have a lot to bear on rehabilitation, if you can call it that. I mean, cognitive improvement, let's call it, in people who have epilepsy. And the mental health aspect is really, really key. And I had the eye-opening experience of hosting a fourth-year psychiatry resident recently. She wanted to do an elective in epilepsy. And on a daily basis, I certainly taught her quite a lot about the care of patients with epilepsy and other neurological disorders. But she taught me quite a bit more than even I know as a person who's tried to be on top of about how to help folks who have depressive or anxious disorders. And no one can be a master of all of that, so having those kinds of other allied health professionals on hand would be just absolutely great.
Great. I totally agree. One day we'll have an epilepsy center that's able to offer that, so that'd be great. So let's open it up for questions. If you are you able to stay on a little bit longer? Just
yes.
for questions. Great. Awesome.
Of
So
course.
just let me unmute the lines.
Yeah.
Okay. Does anyone have a question for Dr. Burghardt?
I do have one question.
Okay.
Mm-hmm.
Has your view on epilepsy changed with things available like the information from the RNS system, which shows you a little bit more of the day-to-day circumstance of what's going on with patients? Has that altered your view on something?
Yes. Before a lot, so RNS or NeuroPace is the brand name is known. This is a device for those who are not acquainted that is implanted in the brain and listens for the seizures to develop and then stimulates to try and break them up. The great thing about RNS is that you get long-term data about what electrically is going on right there at the seizure source without the skull in between. And you know, even the best, the most determined person in the world might not be perfect in recording when their seizures occur and when they don't occur. But the device can record when you have a seizure and when you have a seizure. And so it's given us tremendous information about the variability of people's seizures. Some of the information I cited earlier when I talked about the fact that there seem to be natural cycles where people's seizures can be worse sometimes and better at others. Although this was certainly suspected for a long time, I think the NeuroPace data has just been, I mean, it's been like, oh, duh, that is totally the case with almost all people who have at least this form of drug-resistant epilepsy. And so I don't even treat it as a question anymore, and that ties into my willingness anymore to do that rapid assessment. I now understand, I think, better than I used to, that when a person comes to me and says that their seizures are worse, it's absolutely okay to try some new intervention or an increased dose of an existing intervention to improve things, but it's also important to recognize that when things are better, maybe it's time, because of that natural oscillation of things, to go, let's try and peel something off here. Let's see if we can rid you of some of those side effects. So that's, yeah, it's given me a lot more confidence in that aspect of seizures in people's lives.
Thank you.
Yeah, I have a question.
Okay.
I've been seizure-free 21 years now, but I also am a paramedic, but I also take care of people that have seizures constantly. And one of them, my patient's doctor, she's got 6 to 8 Xanax a day.
Yeah.
And she's been punching holes in the walls and everything. And the parents are getting very frustrated over this. What can I suggest for them to do? She's seen about 4 neurologists now. She's 13.
Well, that's a tough one.
I sponsor about
first
20 people.
Yeah. First of all, congratulations on being seizure-free so long. That's awesome.
Thank you.
Um,
I mean, I'm an artist. I try to get her to do like artwork and stuff with me, but then she'll just get up and put another hole in the wall.
Yeah, and sometimes you get in this really just ugly situation where you're not just treating symptoms, but you're treating side effects from the treatment for symptoms. And no one actually wants that, of course. But it is, in some small number of cases, almost unavoidable. Obviously, I can't give out any particularized medical advice. I will say that Xanax in particular has a fairly short duration of action, and I don't really like using it basically at all if I can get away with it because of that short duration of action. I think people tend to have a better effect with longer acting benzodiazepines like Ativan or Valium or Klonopin. It's also true that lots of people with epilepsy may have, not just because of the seizures, but because of the brain disorder leading to the seizures, may have behavioral disturbances, sometimes autism spectrum disorder, things like that. And there's not a whole lot of people who know how to treat some of those things very well. And I feel like, at least in some cases, the most specialized neurologists, most specialized epileptologists, in fact, might not be the best ones for chronic management either, because the epileptologists at major level 4 centers are often focused on evaluating new patients, getting them to surgery, as fast as possible. And maybe, and this is not a truism everywhere, but maybe not necessarily in chronically managing epilepsy and the comorbidities that come along with it. And that could conceivably lead to a situation where, even though you're seeing very expert people, you're not getting as good care as you could with mental health or cognitive health. And these are, of course, generalities.
I had the brain surgery back in '99, so yeah. Yep.
Okay. Maybe time for one more question. Does anyone else have a question for Dr. Burghardt about complementary therapies? Okay. Well, we will go ahead and wrap it up. I know we there's probably a lot of specific complementary therapies we didn't specifically address, but I think Dr. Burghardt, you did an outstanding job of kind of outlining how to evaluate therapies and recognize when something is potentially dangerous or is a scam or and then also just the value of some of these therapies in not only addressing seizures but also addressing some of the other aspects of epilepsy that sometimes can be overlooked. So really appreciate your time and your sharing your expertise this evening, and thank you everyone for participating tonight. If anyone does have any questions, please don't hesitate to call us at 1-800-377-6226 or visit our website at epilepsymichigan.org. Thanks again, Dr. Burghardt, and thanks everyone for joining us.
Okay. Good night.
Thank you so much. I apologize for keeping you all waiting. Your time is just as important as mine, but I hope this was useful for you, and thanks to Ross and the Epilepsy Foundation for hosting me. Have a great night, everyone.
Absolutely. Thank you. Good night, everyone.